There's a New York Times medical columnist who recently said that medicine has become a team sport. And the team now includes many people playing many roles that the doctor alone used to play. Those two people who used to form the doctor-patient relationship, those two people are now a crowd. And the team approach is central to much of medical care today. Dr. Harold illustrated that. The college is focused on team care. We are fortunate today to have two uniquely qualified experts to talk about this, the cardiac team and the patient in patient-centered care. So I first want to introduce to you Suzanne Hughes from the Preventive Cardiovascular Nurses Association, and following her will be Bray Patrick Lake, who will represent the patient point of view in this discussion. So, Susie.
Thank you very much, and I really want to thank the college and the team here for inviting me to be part of this really important gathering today. So I'd like to talk to you a little bit, first of all, about how the American College of Cardiology over 10 years ago now began integrating non-physicians as members, a real break with tradition for this traditionally physician organization. And then we'll talk a little bit about how the team approach to care is really very consistent with the patient-centered approach. And then I'd like to close with some comments about the critical importance of clinician-patient communication in patient-centeredness. And so in 2002, the American College of Cardiology began to welcome nurses, nurse practitioners, pharmacists, and physician assistants as members of the college. And that group, as a unit, is called Cardiac Care Associates. So that describes those members. And as we heard earlier, the membership of the college is up over 40,000 now. And the membership in this cardiovascular team, the Cardiac Care Associates, is fully about 12%, I think, of the college's membership. And the distribution of members within the Cardiac Care Associate specialty, as you can see, consists of registered nurses, advanced practice nurses, which are nurse practitioners and clinical nurse specialists, and then physician assistants and PharmDs. And the PharmDs are a small but very mighty group within the college. The pharmacists that are involved in the Cardiac Care Associate membership have really been extremely valuable and very collegial in how they interface with the nurses and nurse practitioners. The next couple of slides I'm going to show you really came from the Preventive Cardiovascular Nurses Association and some of the survey work we've done with about 500 of our members. And I think the PCNA membership and the CCA membership are really very similar. So as you can see here, when our nurse members were asked how much time do you spend with patients during the initial visit, the most common answer was 60 minutes or more. And you can see likewise that most are spending somewhere between 15 and 60 minutes. So we, of course, don't have corresponding survey data from physicians, but I think we could safely conclude that nursing professionals may have the opportunity to develop a very close partnering relationship with patients because of the fact that they can spend a little bit more time. And to one of the questions that was asked earlier in the session, like, how do we do this when we're not getting reimbursed? And I think this is a place where we really look at how can we involve the whole team? Because although a nurse's time certainly isn't free, it's somewhat less expensive than a physician's and may be part of the answer to how do we educate patients and how do we introduce them to the shared decision making. And then a second question we asked our nurse respondents is, do you make recommendations for prescriptions or do you prescribe yourself? And even though less than 30% of these respondents were prescribers, look at how many nurses make recommendations about patient treatment to their physician colleagues. And I know when I worked in a community cardiology practice, a lot of what I did was counseling patients on lipid management, lifestyle change, and many times the physician would come out of the room and say, "What's the statin du jour? What should we be using with this patient?" And so very often nurses kind of do develop a specialty, and the cardiologist may be more of a generalist, and they may have an important role in kind of weighing in on treatment. And again, nurses may have insight about the patient's preferences and lifestyle that they bring to the table. And I think another important thing to realize in terms of nurses, even those who are not advanced practice nurses, is the key role that the nursing community plays in patients' long-term persistence with therapy. So who do you think gets those calls about side effects from blood pressure medicine, statin medications, antiplatelet therapy? And so I think nurses are very powerful in keeping patients on treatment. And you know, it's one thing, back to the CCA membership, it's one thing to let somebody join your club, but it's another thing to really fully integrate them as participants in the organization. And this is just one example, a health policy statement that was published last year. This was a team of writers that included physicians, nurses, nurse practitioners, PharmDs, and even patients. And so the college is really very sincere about this component of the membership. When you look at the origins of the nursing profession, the word patient advocate is really integral to the role of the nurse, even from a historical perspective. So think back to your Latin. Advocate comes from vocare, meaning to speak for. And so it's really embedded in kind of what a nurse does and who a nurse is, that we support the patient's viewpoint. But let me point out that all of this patient-centeredness is not intuitive, and it doesn't come easy. And our physician colleagues don't have a corner on the market of the tendency to be paternalistic and even sometimes authoritarian in our approach to patients. This is something that all of us really need to work on. And when we talked a little bit about medical school curriculum or even CME and CE programs, learning these skills isn't a didactic process when somebody stands up here and tells you how to do it. It's learning that is done through role playing and practice, and that's just a little bit more challenging to do. And so we're all practicing, we're all working at it, and we will get better over time. And we can see from this comment made by Dr. Ralph Brindis during his year as ACC president, based on survey information from the college, is that those who operate in a team-based format show increased efficiency, so translated as cost and value, improved quality of care, and increased patient satisfaction. So that's Berwick's triple aim, right? Quality, patient experience, and cost. All increases based on a team approach to care. So let's get a little bit more into the weeds about a patient-centered healthcare system, because it's not just about those two people in the exam room or at the bedside and how they relate person to person. It's also about our processes of care and then our greater sort of total health system and how it's organized. So in how we all relate to patients, this particular sphere of patient-centeredness is probably more within our control than the other two sometimes are. And it's about listening. We know from well-referenced surveys that when a patient comes in and is stating his reason for being there and his problem, the average length of time the patient talks before they're interrupted by the clinician is somewhere between 20 and 30 seconds. But we also know that if a patient is allowed to describe his needs or his wants or his concerns uninterrupted, the length of time is about 93 seconds. So it really doesn't take that long to be patient and listen and kind of get to the root of the problem. It's also important that we use empathic communication, and in particular, when we're working with patients on lifestyle change. We have to get away from all those shoulds, and we have to be able to relate to patients in a way, in a human-to-human way, that we recognize their challenges. Knowing the patient as whole and unique, as Minna talked about, the shared decision-making, knowing kind of what makes that patient tick and finding that common ground based on their preferences. And it's also important that we look at our entire team. So that patient-centeredness really starts when the person walks into that office and somebody thrusts a clipboard at them. That's where patient-centeredness should really start. And so we have to look at, how we treat that patient from the moment they enter our space. And really utilizing all of those team members can make a tremendous difference. So much is being asked of physician providers to do. Patient education, shared decision-making, empathic communication. If the physician isn't leveraging all members of his or her team, he's not going to be able to get the job done. And then the second sphere, a little larger, is how our care is provided. Are we working in a setting where we employ shared decision-making tools? Do we, in our practices, make available to patients things like using a home blood pressure monitor and either emailing results, or are we using telehealth processes to communicate with our patients? Do we maybe work in a setting where we encourage patients to investigate having a home INR monitor where they can monitor their and help us more appropriately adjust their doses of warfarin? Do we have information systems that when the patient comes to see us after a hospital stay, we can put our hands on that discharge summary and those homegoing instructions? And do we work in a system that supports telephone encounters? And then our larger systems of care, and I think this is really important, and we heard this morning that the college has a layperson as a board member. Well, in your hospital system, do you have the patient community represented on your board? Do you have a hospital system where the directional signs are appropriate for those that may have trouble reading and understanding, or maybe for whom English is not their first language? So our systems at large also need to become more friendly, and certainly IT is a huge part of this. And as we begin to work with our patients on shared decision-making, we have to start with the first step of making sure that our communication is clear. And I was thinking with something Henry said earlier, my dad was a lung cancer patient, and when he would go for his regular chemotherapy treatment, he'd have all his blood values measured, and if his white count and his was appropriate and he wasn't anemic, then he would be proceeding with getting his treatment. And the very well-meaning oncologist would come in the room and say, "Well, how are you feeling, Bill?" And he'd say, I'm feeling like really bad. I really feel terrible. I'm really tired and so on." And he'd say, "Well, your lab work looks okay. What do you want to do?" And my dad would say, "Well, how the hell do I know? You're the doctor." And would it have been so hard to say, "Okay, your blood count's all right, so we could give you your treatment today, but being that you're feeling so terrible, we could also wait a week, and either way would be an okay choice." So we have to introduce this to people in a gentle way, particularly our senior population. You don't just ask people, what do they want to do, or what's their choice? You have to tell them a little bit about both of the choices would be reasonable options. And so we get into the whole area of health literacy, and we know that overall only 12% of the population in the United States is really proficient in terms of their health literacy. And communication is a two-way street. And as we begin to really work on how we communicate with patients, you've probably heard a lot about the strategy of teach back. And teach back is when a clinician tells the patient what they need to know, and then they say something really non-threatening like, "Oh, I know I've given you a lot to think about today. Help me confirm that I've done a good job, and tell me when you get home, how you're going to weigh yourself every day and what you're going to do about that." And that isn't to test how smart that patient is. That's to test how good you are. And you really do need to have that teach back to confirm that what you said is indeed what the patient heard. I think this is interesting. As Minnow mentioned, a lot of the literature on shared decision making doesn't really come from cardiovascular care. It comes from primary care and also from cancer literature. And many times, clinicians very sincerely think they know what's important to patients. And so when these doctors and female patients with breast cancer were asked what was important, you can see that what the physicians thought was important to the patient wasn't necessarily what was important to the individual patients. And so shared decision making, very simply, is a meeting of two experts. The clinician is the expert on the disease process and the treatment options, and the patient is an expert on what's important to them. And so Minnow stole my story, but this was actually a pal of mine who took his father to a retina specialist, and he had macular degeneration, and he went along with his dad, who was, I think, a man in his 70s, and the specialist went very respectfully through all the information, the disease process, what they could do, and used, of course, the lingo of his medical specialty. And when he was finished, my friend said, "Can you go through that again? Because I don't know the language of your specialty." And that friend of mine was an FACC. And so we're not talking about dummying it down. We're talking about using a common language. Think about if someone came to talk to you about how you needed a new furnace, or you were getting your car repaired, or how you communicate with your accountant when it's tax time. You want to hear that in language that you understand. And so, as I mentioned earlier in the question area, there's really two schools of thought in health literacy. Do we test everyone? Do we talk to them about their educational level or how well they read? Or do we use a universal precautions approach and communicate with everyone in living room language? And it is sometimes difficult when you develop patient education pieces to do those readability tests, because when you get words in documents like familial hypercholesterolemia, guess what that's going to do to the reading level when you use those gauges. And we have to use some of those words because that's what that is. And we have found that the best way to test our materials is to have patients review them before they're finalized. Real patients in the real target population, all colors, all sexes, all ages, and make sure that we're hitting the mark. One of the reasons this information is so important is that our cardiovascular patients are older. And this is kind of scary, but when you're 65, if someone would do the TOFLA test on you to see what your understanding is of something you read, no matter where you are, by the time you're 85, your understanding or your health literacy level is going to decline. So as you can see, our patients that we deal with in the cardiovascular world, by the time they're over 75, there aren't many who are still in that proficient category. And so you may be talking to someone who's a retired chemical engineer or a physician or very educated, well-spoken person, but as we age, our ability to understand complex information indeed decreases. And so all healthcare professional societies are working very hard to develop patient-facing information that is easily understood. And at PCNA, we actually developed kind of a style guide that kind of put a stake in the sand about what our materials would look like. And it isn't only about, the length of the words or the syllables. It's also about starting out with what the patient really needs to know. And it isn't the heart is a four-chambered organ. It's what they need to know to take care of themselves. And that it helps to clarify things that are difficult to understand. And we also really wanted to establish standards for the writing style and the approach to the reader so that it should be warm and supportive. When you're talking to patients, we try to avoid things like should and kind of that whole preachy approach. And to use interactivity, quizzes, things that engage patients, really make use of adult learning theory. You learn better if you're interacting with the material and if you stop and chunk and ask questions. And I think that we have learned from what we've heard this morning and will hear as we move on today, that our patients do want to be involved, they do want to participate in their care, and by involving them, we will be meeting all three tenets of healthcare quality, and that is improving the patient's experience with care, increasing value and decreasing cost, and importantly, improving our healthcare outcomes. Thank you. Should we do questions at the end?
Yeah.
Okay.
Hi, everybody. I am Bray Patrick Lake, and I'm here to speak to you as the patient, and mostly as a person, I feel like. I mean, really, we're all patients. So without knowing it, Dr. Solomon very masterfully played into my plan. I think you wrote down what the definition of patient-centered care was, right? You did that earlier. Okay, so for the purpose of my talk, I'm using the IOM definition, and I was wondering if any of you had this almost verbatim, or if you had all these key elements of this definition. Don't be shy. Okay, I see three of you, and the good news is I'm going to let one of you come up here and give my talk. So you, sir, if you would like to come on up. So I really want to start the story at the beginning. I feel like as a patient, we're a bit asleep at the wheel. So a lot of us are going along, we're enjoying our good health, we might be going to our annual exams, we're really not thinking about being a patient. And then something happens. You either have some type of medical event or you have a diagnosis that you receive. In my case, it was at a bit of a young age for congenital heart disease, and I'm like the most fit person in my family. I eat good food. My parents have made it to 70. I don't want to go too much into to trashing them, but I think they don't exercise very well. They eat a bunch of junk, and they've yet to need to see a cardiologist, and it's just a bit baffling. So I was really particularly unprepared. All of a sudden, you get your diagnosis, and you find yourself transitioning from somebody who's just kind of an average person to the patient. And we really aren't prepared to even participate in this conversation. You go into your appointments and it's a foreign language. You're not thinking, disease management, risks and benefits. And as patients, we're increasingly moving towards participating in our own care. And there's been an increasing need that we've shown that's been documented, and there's a lot of research on it. But there's still a process of becoming a good patient, and it requires support from your physician. It requires the team care model, in my opinion, that's the comprehensive getting patients information and helping them navigate this process that they're coming into not necessarily eyes wide open, kind of learning as things go on what's important. A lot has changed over the course of the years as well. We're seeing that transition from paternalism, and the continuity in care is really kind of gone. It's very few families now, I think, can say that you've had that same family physician. I grew up in Atlanta, Georgia many years ago, and we had a physician that saw my grandparents, they saw us, they saw certainly everyone in the family and a lot of people in the neighborhood. And it was a different type of relationship because that person really could say, we know this patient's values, we know the family, we can guess in this circumstance what this patient would want or how this patient might react to a certain therapy, what their lifestyle is, if they're going to be able to adhere to a treatment. Now I know particularly a lot of us find ourselves seeing a physician and formulating relationships based on our insurance and saying, this is who's now covered, how are you going to get to this person? And so those same relationships are not in place. And that's really kind of complicated things. Physician-patient relationships, you've only got so much time, and in walks this patient. So our younger patients now, we're smart, we're empowered, we are on the internet all the time, we want lots of information, we want autonomy, but we might be a little unprepared to navigate the decision-making process. And I've actually heard physicians say, well, when dealing with people who are your age, where's the room for the physician? It seems like the decisions are already made. You've come in off the internet, you've got this, and you've already decided you want this treatment before you've even gotten in the room. And so I would say from the patient perspective, please, we do need the physicians, and if we don't see that clearly, you need to help us understand that. But if you look at some older patients, they can become kind of overwhelmed with information, and we heard Dr. Walsh speak about this earlier, where you really do want that patient to participate, but the patient themselves might be saying, gosh, I'm not smart enough to do this, I can't read this, I can't understand this. And so there is no one-size-fits-all patient these days. And then my all-time favorite, I really do love the people that just go, well, just tell me what you would do. Shirking any responsibility in making a decision. Some people, I think, have been conditioned to do that, but if something goes wrong at the end of the day, guess who's holding the bag? The patient's not really going to be the one to say, okay, accept that I didn't make that decision. So here's some issues now where we need to start looking more at patients as people. Physicians in practice, and particularly some of our junior physicians as they've come up, you've come up looking at patients not quite holistically, depending on your training program. I think some training programs are really getting a lot better at patient-centered care and patients as holistic type of a holistic vision of the patient, I guess. But some people may be looking more at patients as research, and that patients should respond in this way. We talk a lot in research about heterogeneity of treatment effect, and that one patient might experience a different benefit or more of a benefit, when really, a lot of times, I think the confounder is the patient out of the research world. When you look at practice, the patient that's going to do the best is the one that's actually going to adhere to the treatment. The patient that's going to do the best is the one that's going to manage their weight and manage their blood sugar. These are all kind of things that are the moving variables. So how do we manage that? So physicians, you really could manage that through education and tools, but there's some challenges to this. Where are patients getting their information? I put this picture up of this kid with this phone because this is a child who's developing apps. And I say child, I mean, he's like a teenager. But when your patients come in and say, hey, I tried this new app, we really don't know. We haven't validated that. Does it really improve outcomes if they just downloaded something off the internet or put it on their cell phone? We really don't know exactly, what is the value of that? Patients, again, we're still trying to decide what type of information we need, where we get it, and what it means. I just randomly in Google put in coffee causes cancer and coffee cures cancer. Guess what? It does both. So if one of you can tell me which, I don't know, I'll have some more today. But there is increasing research that shows patients are legitimately trying to engage and trying to be part of the healthcare system, even if we don't know how exactly to do it. And a key barrier right now is finding a trusted source of information and trying to find a trusted source that's kind of that pathway to engagement. You may have read in my bio that I manage some online patient communities. I do this for cardiology and for a crossover neurologic condition. And this is a real post, not in my group because we actually have qualified cardiology medical advisors. But for those people that have patent foraminal or atrial septal defect, I don't know if you knew this, but closing your PFO actually does change your sexual benefits. So this was an entire patient discussion. There was another one that I didn't cut and paste and put in here that was about how if you close your PFO, your eyes turn blue, which I thought was great because our next trial can now be funded by Bausch & Lomb because we're really out of research funding right now. But there's all of this stuff that's going on where patients are trying to engage, but maybe we could do that in a better way. Also, patients, we've heard that there's data out there. We've heard about registries. We've heard about quality improvement. You go in and now a lot of reimbursement might be linked with collecting data. So we hear data, 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 but I'm not sure we really know what to do with it. So you can talk to a patient about data. You can try to explain the randomized controlled clinical trial that this is the gold standard. But yet in an online group, a patient will hear that another patient said they had this benefit and this is exactly what they're expecting when they walk in the door. And to that, you might just say, really, statistics are for people that lack good anecdote, which I think is fine, but it's still an issue that's got to be managed. So what exactly is unbiased scientific information and how do patients get it? We talk a lot in the research world about data that's collected in a scientifically meaningful way, and that if you're participating in the national conversation on data sharing and transparency, certainly the full disclosure of results, negative results being as important as positive results. Data that's presented to patients without a preference or a bias. And Dr. Walsh, I'm trying to remember, it was you and was it Dr. Lewis discussing about how you try to present the same information exactly the same way to the patients, but your personal bias still managed to come through and influence their decision. So sometimes it's not quite as straightforward, even when you do make that effort. I think there's still got to be some type of tool, and we're still doing a lot of work around that, particularly at the Shared Decision-Making Committee. Data that's presented by an unbiased party. I know in industry, we have a lot of industry folks here this afternoon that you work hard, you get data, but there's still kind of, from the patient perspective, that there can be a lack of trust sometimes or a lack of confidence when it comes from industry. And I heard a physician one time, I said, well, where did you get this information? He said, well, this pharma company created this pamphlet and then handed it to me. And the patients in the room, I saw like the nails on the chalkboard, and it might be true, but I think if there's the mitigator of the patient advocacy group or the professional society who's saying, yes, this really is the best data, then we have that relationship. And then we actually can, I think, participate in our own care and decision-making and have trust in that type of data. I happen to do some work for Rob Califf, for those of you who know Rob Califf at Duke, and Rob talks a lot about the type of evidence that's out in the community that is influencing patient care. And there was a study that was actually done that showed that about 25% of even professional guidelines may only be based on randomized clinical trial data. So there's an opportunity here with registries and different mechanisms of collecting evidence, particularly with the advent of PCORI, to look at some of this evidence and figure out how to translate it in a meaningful way and get it back to patients that allows them to participate more in their own care. So the gentleman in the front table, you can present this slide. I was talking about the challenges of healthcare reform and how it really is kind of being pushed through on the back of providers. If you talk to any physician today, I think they'll tell you they spend less time face-to-face with patients, more time documenting, and then really trying to figure out, how do I even get this therapy covered for this patient? I think offices can say that we are spending more and more time on this. So how do we do patient-centered care? Isn't that going to make it even, one more thing that we have to do in the day? But CardioSource had some really good information that actually showed that there are some misconceptions. It really doesn't cost more. That changes in attitude, kindness, and personalized care optimize patient and family interactions. There are good reasons that we should be doing this, and you're not necessarily going to have to hire more folks to do it. So to go back to the Patient-Centered Care 101, the why that we need to do this, certainly improving health outcomes and quality of life. It's also, I think the bottom line of this slide is it's the right thing to do. So my conclusions, patients are craving education, empowerment, engagement. We really want to be seen more as the p-value and more as your partner in care. We really need to work more on our trusted relationships and employing the cardiovascular team member model with the patient being part of that team. And if we don't, really, I think we're all shorting ourselves. The wheels are just going to continue to spin until we can get some tools and some strategies in place that allow the patient to be a full partner in their care. Thank you.
So Susie and Bray, thank you so much. A couple of thoughts of mine, and then we're going to open up the floor. As far as the coffee, since I drink 10 cups a day, I can tell you that the only valid evidence is the good stuff, the stuff that tells you it cures everything. As far as, the problems as people get older and lose some abilities, aging is a complicated issue to deal with. There's a simple way to remember it. There are 3 cardinal signs of aging. The first is loss of memory. The other 2 I just can't recall. The pharma people, when I was in pharma, and consulting for a pharmaceutical advertising agency, there were a series of ads for a series of products for urinary incontinence. Different pads, different things. Everybody's ad compared how absorbent their product was, how much liquid it could hold before it leaked. One pharmaceutical company decided that's not what the patient really wants. It was ads designed for women. And the ad and I say we because I was consulting for them, the ad we put together showed an elegant, beautiful woman dressed to go out to an elegant party. Had nothing about absorbency, how much stuff it would hold. What it said is, they didn't have to say it, the picture showed it. You use this product, you can be the elegant woman you wish to be. The product became #1 in its category. I didn't think of it back then as, patient-centered, patient gold, but when I think of it now, it's exactly what it was. In terms of communication, it is obviously important, but as one of you pointed out, sometimes the patient doesn't want to get engaged in that. A friend of mine treated a veterinarian. The vet came to my cardiology colleague's office, and the doctor started to take a good detailed history. And the vet said, when I treat my patients, I don't have a history. I just look at them, I know what's wrong. Why can't you do that? So my friend looked at her, said, okay, here. He wrote out a prescription, handed it to her, and said, by the way, if it doesn't work, we'll have to put you to sleep. The last thing I want to say, and this is serious. When I practiced, I was a solo practitioner, very small office staff. We didn't have a team, but I like to think that we did practice patient-centered care. So I would argue if you go to a physician and you don't see a whole team, you could still have people doing patient-centered care. A good friend of mine, just 1 month ago, he has been under chemotherapy for a form of lymphoma. It was 4 months after his last treatment, and he developed fever, malaise, and weakness. It was a weekend. His oncologist wasn't around. He went to a local urgy center. The doctor examined him, and there was nothing really to find. He had fever, took a blood count, and his white count was practically 0. And the doctor said, well, the machine is broken. I can't tell you what your white count is. The doctor's nurse, it's an urgy center. They didn't know this patient. The nurse said to the doctor, maybe it's real. Doctor said, don't be ridiculous. The nurse took her own blood, ran it through the machine, and had a normal white count. And the doctor said, my God, this patient has to be in the hospital. Now, I would argue that nurse did patient-centered care, didn't fit any definition, wasn't collaborative, wasn't communicative. That to me. So maybe we can come back to that during the panel. It's all about caring for the patient, as Dr. Peabody said in 1926. So, floor is open now, obviously. I didn't mean to pontificate. Comments about Susie or Bray's talk or anything that's on your mind about this kind of a thing, the role of the nurse, the patient. I'd love to hear from some of the pharma people. You're all trying to communicate with the patient in one way or another. And Dr. Alessi this afternoon is going to talk to us about how pharma, your organization, is doing some patient-centered things. But how are you looking at the patient when you plan your campaigns? Anybody, please.
I remember,
Yeah.
this is some years back, but I represented our nurses organization at a FDA advisory committee meeting when J&J Merck was working to take lovastatin to OTC status. And I got up and gave a statement, which was fairly benign, about how if this did become available, how it would need to be accompanied by, good communication, patient education. And one of the physician panelists, who was quite adversarial, asked me at the end, so we doctors can't get patients to take this medicine. What makes you think patients would take it on their own? And I said, what makes you think they wouldn't do better? Because when people really are able to have a choice in identifying the therapy they want and they seek it out, they do have a greater sense of ownership for it. And I think we have to recognize the role of that in patient adherence in the whole patient-centered care model and having patients participate in their decisions.
Yes.
Hi.
Yeah, hi.
I enjoyed the talks immensely. And one of the things we like to look at and think is very important when designing patient education and programs is to really incorporate this idea of cultural literacy and to understand how a patient likes to receive information, the types of information and the places and the venues. And I think a lot of the organizations here do a great job with reaching out, on a cultural basis. And so I'd like to hear your thoughts on that.
It's interesting, we just had a piece on FH, which we talked about, and we had it adapted for audiences in Australia and in the UK, and you think, well, wait a minute, everyone speaks English. And it was interesting to us how our colleagues in other parts of the world wanted some of these patient-facing pieces to look just a little bit different, like the pictures of the people, obviously, and some of the different maybe scope of practice issues for nurses in other countries. But we made significant adaptations to be culturally competent in other English-speaking countries. So it's really important to look at your audience and find out what they want and need. We know that some cultures in the United States communicate messages by telling stories. We know some cultures, there's very paternalistic family structure that, maybe the elder male is like the learned person that helps make the decisions. And so you really have to develop materials knowing things about different kinds of people. And it gets, I think, more and more complex as the composition of the United States changes too.
So I would like to add to that to just say that sometimes I think you need to go to the group itself and ask, particularly with the community engagement piece, if there's a cultural issue, what is it that you need and how would you like to receive it? A number of points that Suzanne just made I could speak to, but there was a great example where somebody had created some very thoughtful patient education materials that had a picture of a woman's feet, or her feet were shown, and then the culture that they were actually trying to reach that was very disenfranchising and unacceptable, and they didn't realize it. So without asking them, they wouldn't have known.
Yes, Amelia.
Hi. This conversation has changed so much over the years, and I know that we really struggle now with reaching patients where they live. So social media and blogging, and really reaching out to patients where they're getting their information, not outside the doctor's office, outside of DTC. So with that said, though, from a pharma standpoint, there's a lot of regulation and a lot of firewalls about what we can and can't do in that space. And I think that's really where we need to find patients, but we're also struggling with how to do it compliantly.
The restrictions on pharma are enormous, but my feeling is, and having been in pharma and been in practice, there got to be creative ways that you can do this that are within the appropriate limits and boundaries. Yes.
Hi, I'm Cindy Riley with the American Society of Health System Pharmacists. I guess one of the things that struck me is Bray's slide related to the time spent, speaking with patients versus documentation. I have a very similar slide that I use when I present to my members in terms of the challenges with that. And I think, everyone in this room would agree that, the patient input perspective in this process is important, but it all comes down to the challenges of the environment. I guess I have a question in terms of how other professions are managing this. One of the things my association has done recently, a joint project with the American Pharmacists Association, is looking at different models of patient education, specifically at transitions of care, discharge, to prevent readmissions. And one of the things that we found is, everyone does it a little bit different in terms of, do you counsel patients on their medications when they're discharged, 5 days, or, well, it's never 5 days before they're discharged, they're not there that long, 2 days before they're discharged, 5 days after. And we do find that different models work differently, and I think some of that can be predicted based on the models, but I think also in terms of considering the patient's perspective. I mean, we know that discharge is not a teaching moment. Some patients may learn better different times in terms of where the emotional spectrum is. And then also, I think another important thing is that it's time dependent. So the patient decision on what therapy or what course to do, it may seem right at one moment, but I think sometimes people forget you got to go back and reassess that 5 days later they're having an adverse event to the medication, and maybe that's no longer the right course, and that that needs to be reassessed. And I guess I'm just wondering, are other professions looking at different models, or from the patient perspective, what do we know in terms of the timing of the intervention, in terms of what makes it most effective?
Does anybody want to comment on that?
Well, I think there's fairly robust literature that the teachable moment of discharge is very powerful, but you're making a very good point that the time in the hospital is significantly shorter now than it used to be. And so, and patients in the hospital are significantly more ill than they were a decade ago. So the amount of information given to somebody at the time of discharge, even though it is that teachable moment, and we have data that if you leave a hospital on a medication, you're more likely to continue it. Those are all true, but I think it's a changing demographic, and there's a lot of information given at a time when, as you say, patients aren't always receptive. In my practice, every day, even in our own healthcare system, met with patients who didn't understand what medicines they were supposed to be on. Somebody held a medicine they were on before, they don't understand, and they view the office visit as the time to reconcile that, and that may be, well, in our case, because of heart failure, we do very short off, but they may not have been on the medication for the period of time, because I'm going to check with you to find out. So during that period of time, they kind of abdicate the decision.
Yes.
I'll just give one example of what we do relative to this. We do hypertension and CHF, remote monitoring, and patient education engagement when they leave, when they go into the home. So we've spread out in the U.S., our company's actually based in Germany. In the U.S., we do a 30-day program where the first week after we'll talk to the patient, and we use a lot of AHA materials, but we engage them over the telephone, which is the least common denominator. It's not necessarily online or via a smartphone app. And talk about the risks and complications so they understand what might happen if they don't manage this particular condition. The next week, so we break this up, the next week we talk with them about the medications, the types of medications for this condition, what medications they're on, do they understand how they work. The next week we talk about lifestyle, the things that they need to change. And then the final week we go through into a test. Now, our colleagues in Germany, they do longer term, they do it at 12-month and 18-month sessions, and they'll spread this out over a longer period of time. We're typically a little more interested in faster results here, I think, in the U.S. But that's an example of breaking it up over time, engaging the patient when they're at home at a time that's scheduled, that's convenient for them. The first question we ask when we call, is this a convenient time to talk to you? And then we go into our questionnaire before we go into education. How are you feeling? Have you had any changes in your health? Have you had any changes in your medications, et cetera? So we found that that's fairly effective. We'll be publishing something this fall, combining the remote monitoring with that approach and the outcomes and the patient experience changes that occur.
Yes, Ray.
One comment regarding the appropriate setting for, med education, et cetera. I think one of the most important time periods, and Dr. Walsh alluded to this, is that first week after release. And so all our high-risk patients are seen generally by an advanced level practitioner within the first week. And then it's not all about hospitalizations. There is a lot of importance that needs to be placed on emergency room visits and how to transition those back to primary care offices within a few days. And I think the metric that tracks all that is the readmission rates, and certainly the government has a big interest in readmission rates now through value-based purchasing, otherwise penalties. And so I think those early visits, that's the setting that we found the most beneficial regarding education. And typically those visits are longer than would be with a physician.
Yes, Dr. Leslie.
It's just a comment and kind of a reflection. I think I want to highlight the importance of what was stated about building relation between patient advocacy organization and the industry. And I guess my colleagues here also will agree that there's been a lot of progress in that, also on the communication standpoint. We are moving, at least a lot of companies are moving more from a communication tailored more towards marketing versus, synergy with alliance development, understanding, much more what the needs of the patients are, and building long-standing relation. But one comment I also want to make related to that is, as we all go together to this process, and I think we build better relation, it is also important to remove some bias, because I guess this relation have to be based on trust. And if assumptions are made that whatever communication comes from the industry is biased because there is only a commercial interest, I think you remove an important part, which is a lot of the people that work in the industry are some of the most knowledgeable people about, not just the product, but the science behind this and so on. So I think that we should look this in the perspective of building a relation, building trust. It's both about, communicating effectively, but building something that it is truly a partnership.
Yes.
Comment. I'm a teacher in my day job, and one of the things we try and do, and it's very difficult, but we recognize that students learn differently, and that's probably the same for patients too. Some are visual learners. They might need a picture. Others might need a model. Others might want a 40-page document to read on their own, and I think that's something that might help with the patient communication and understanding.
So one last, yes, go ahead.
One of the things we've been struggling with is how we not only worry about what we communicate, but who communicates it. So back to the whole trusted source of data, right? So the patient is interested in the information, but the information's internalized based on who told them and when they told them and how they feel about that person. So I think industry is working harder with their partners in the patient advocacy arena to figure out how we work together. We have the expertise, and they know the relationships with the patients and the right place and time. And the who should be in the room when information is shared. So that's something that a lot of industry is working toward.
Yes.
I would also put on the table that industry does a lot of research. These patients are also our customers, so I would say that when you have a patient who comes in with information on a specific drug, ask them why they chose that specific drug. A lot of times that aspirational goal is in that advertising. They want to walk down to get the mail. They want all these things that they see. They cling to that, and that gives you, as a healthcare provider, the opportunity to have that conversation. That, if you just stop and say, why, what drew you to this drug? Why this drug? Why are you, interested in this? Because we do a lot of research with patients to find out how we are going to make that communication to what it is that is important to them for this disease state.
Sometimes this one last quick story, the content of a conversation and who delivers the information is important. The space agency and NASA was interviewing professionals. They wanted to send someone to Mars who was going to be a one-way trip. I mean, the person knew he or she was not coming back. So the first applicant was a cardiologist, wanted to get out of practice. The interviewer asked him how much he wanted. He said, I want $1 million, but I'm going to give it all to my university in California. The next applicant was an engineer. Interviewer asked him, he said, I want $2 million. I'll keep $1 million and I'll give $1 million to research in engineering. The third applicant, you can imagine, was a lawyer. He whispered, I want $3 million. And the NASA interviewer said, why so much more? He said, well, I'll tell you what. You give me $3 million. I'll keep $1 million, I'll give you $1 million, and we'll send the cardiologist. So we've come to the end of our morning. We're going to be approaching a new and different part of the consortium. We've never had a panel before, those of you who've been to consortium meetings. But patient-centered care is a team effort, and so we wanted to have a team. But there's something more important. There's a psychologist who said, you cannot drink the word water, and you cannot get wet from the word rain. Words alone keep you several steps, maybe, from the real experience. So we have assembled a panel for our luncheon panel who really don't just know the words, but they live the experience. We want you to hear about patient-centered care in the real world and a concrete way that the ACC is approaching it. Dr. Walsh is going to lead the panel, but before we do it, I want you to go outside, get lunch. Please bring it back in as quickly as you can, and during your lunch, Dr. Walsh will conduct a panel with other guests. Okay, please go out and let's eat.